new onset atrial fibrillation, or new as far as we know, in the setting of an acute either surgical or medical stressor, how do you think about these patients?
If I'm consulted for a patient with new onset atrial fibrillation in the hospital, whether it be from non-cardiac surgery or acute illness, I kind of go through like a progression in my head. First is the acute illness bleeding? And I think that's the most important because if the acute stressors from bleeding, the risks certainly outweigh the benefits. So I always think, is the stressor bleeding? And then my second question is the complete polar opposite question is, have they had a stroke before? Maybe it was a stroke labeled for another reason, and maybe we need to rethink it. Maybe that stroke was an embolic stroke, and we are now unearthing what the true etiology of a stroke was 8 to 9 months ago. If the patient has a CHA2DS2-VASc score of 0 or 1, we wouldn't be anticoagulating in the community anyway. I think if a patient's CHA2DS2-VASc score is 4 or greater, even in the absence of any atrial fibrillation, they have a stroke risk that's actually relatively high, even with a small burden of atrial fibrillation that you see in the hospital. And there's actually a study out of Israel that you can see in the American Journal of Medicine in 2016 from Walid Saliba that actually showed that high CHA2DS2-VASc scores predict the incidence of atrial fibrillation. So in patients with CHA2DS2-VASc scores of 4 or higher, and they have atrial fibrillation, unless there's a major bleeding risk, I'm going to err on the side of anticoagulation. It's those intermediate patients, which of course end up being the large majority of them, with a CHA2DS2-VASc score of 2 or 3, where actually there is some, albeit not robust data, but some that suggest that atrial fibrillation burden does have a role. There was one study in 2009 that, and again, this is all the studies that look at this are in patients with devices as an outpatient that are looking at subclinical atrial fibrillation. So it's hard to equate subclinical atrial fibrillation stroke risk to post surgical or inpatient stress atrial fibrillation stroke risk. But there's a paper in 2009 that showed that patients with a CHA2DS2 score of 3 and no AF have a similar stroke risk of patients with a CHA2DS2 score of 1 and continuous AF. So when you talk about these low to moderate kind of CHA2DS2-VASc scores, I think burden is important.